Good afternoon, everyone. Welcome to all our participants joining us today. My name is Dr. Vijit Sangma. I'm the Secretary for the Doctor Section of CMAI, and I'm honored to serve you as your host for this vital conversation. As we gathered for our webinar series, Understanding Practical Bioethics, this is organized by Christian Medical Association of India in partnership with the Center for Bioethics and Christian Institute of Health Science and Research, Dimapur. And today's topic is withdrawing or withholding life support. And it has never been more relevant as we are witnessing a historic shift in India's legal landscape. The Supreme Court has recently allowed the first ever withdrawal of life support for a patient in persistent vegetative state, making a significant milestone in the journey of passive euthanasia in our country. With the judiciary has opened this door, it has also highlighted a critical gap. The Supreme Court has just today's news has strongly urged the union government to bring in a formal law on passive euthanasia to provide clear guidelines for the medical community. And currently, in absence of any comprehensive central statute, the weight of these tough decisions fall directly on us, the healthcare providers, the ethics committee, and the families. We are operating in a space where legal precedent is evolving, but clinical reality remains challenging. This webinar is designed to help you navigate this transition. We are not just discussing theory while looking at how to apply these mandates to our hospitals, ensuring we provide dignity to our patients while staying within the evolving legal framework. Today, it's about moving from legal headlines to bedside practices. And to lead us through these complexities, we are joined by two exceptional leaders. Our moderator, Dr. Rupa Verghese, is the Executive Director for the Center for Bioethics and a trained obstetrician and gynecologist from CMC Ludhiana. She holds a master's in bioethics from Trinity International University, Chicago, with over 20 years of experience serving both remote clinical settings with the Emmanuel Hospital and in the past in corporate healthcare leadership. Dr. Rupa brings profound depth of clinical and ethical expertise to her role as a moderator today. She will also facilitate our session and ensure your questions are addressed during the Q&A session. And our resource person, Dr. Ashita Singh, is a family physician at Chinchpara Christian Hospital and head of the palliative care program at Emmanuel Hospital Association. She holds MD in internal medicine from CMC Ludhiana and Masters in Bioethics from Trinity International University, Chicago, with specialized fellowships in infectious disease and palliative medicine. Dr. Ashita has extensive experience in critical care and is uniquely qualified to guide us through the complex practical and ethical dimensions of life support decision. Dr. Ashita, the floor is yours for the presentation on withholding and withdrawing life support.
Yeah, I'll welcome Rupa to start our discussions.
Thank you. Thank you, Abhijit. Thank you, Atamla, for putting just a wonderful start to this topic. And I think without any further ado, I would just welcome each one of you. Good evening, everyone, and welcome to this session on one of the most critical and emotionally charged areas of healthcare, the ethical, legal, and the compassionate management for withholding and withdrawing life-sustaining therapies. Minimizing suffering and ensuring patient autonomy in their final inevitable journey. So when a patient's condition is irreversible, deciding between withholding and withdrawing a life support is a complex process. While these approaches are often discussed together in the clinical ethics scenario, they really carry a different emotional weightage for the families and the staff. So today we intend to discuss how to navigate these complexities while maintaining professional standards. This session, we are mainly focusing on the ethical aspects of the treatments We will also have another session that deals with the legal and the practical aspects of the same, especially in India. So without much ado, let me jump into a very common flow for you, Dr. Ashita. Let's say we have Mr. Kumar, who's diagnosed with cancer of the lungs for the last 11 months. Despite all his treatments that he had, this disease has progressed to an advancing stage with him having the secondaries in the liver and the brain. Now, he's been completely bedbound for the last 2 months, fully dependent to his family members for his care. He's also become now drowsy, and family members have brought him to the emergency room. They want everything to be done for him. His blood pressure, I think a very common situation which most of us would have faced. His blood pressure on arrival is on the lower side, 80 systolic. His oxygen saturation is varying between 83 to 85%, and he has a very low sensorium. Dr. Ashita, do you think we have any options for this individual, or it's just very straightforward? You go ahead and you just start him, intubate him, and you take him. Like how would you want us to think about this case?
Yes. Thank you, Rupa, and thank you, Abhijit, for that introduction. Yeah. And good evening to all of you, and welcome to this session. I hope that it's a time of, just us digging deep into our hearts and our minds and trying to understand how to think about these issues, which are actually everyday issues for us. But I remember as a young physician, often feeling very much at a loss and wondering whether I was thinking the right way, whether I was making the right decisions, what's the right thing to do. There's so much conflict, yeah? So as Rupa introduced this patient, we have, so what I'd like is for all of us to think about this, just to form, sort of a foundation on which we can have a little discussion on this, on these issues at the end of life. So to summarize again, Mr. Kumar, cancer known for the last 11 months. He has had some treatments, but for the last 2 months, he's deteriorating. Now, and he was almost fully bedbound, dependent. Now he has become drowsy. So the family got concerned, and they came to the emergency room. And they come to the hospital and tell the treating team that they want everything to be done for him. And Mr. Kumar's blood pressure is low, his oxygen saturation is low, and his sensorium is low. Okay. So just for us to stretch our minds a little bit, what I'd like all of us to do is just in the chat box, look at the options. Are you able to see the questions in the box? But I'll just summarize them anyway. There's 3 options. The first option is that Mr. Kumar should be immediately intubated as his oxygen saturation is very low. And if we intubate and ventilate him, then his oxygen saturation will improve. And so we should intubate him. So if you choose that option, just put 1 in the chat box. The second option is Mr. Kumar has a progressive terminal disease and is unlikely to make a recovery. Now, we as healthcare professionals know that, but the family is telling us to do everything, So the doctors therefore have no choice but to intubate him and put him on the ventilator. That is option 2. And option 3 is Mr. Kumar has a progressive terminal disease. Intubating him and putting him in an ICU on the ventilator will isolate him from his family, will cause him discomfort. Furthermore, although the oxygen saturation may improve temporarily, the underlying disease is only going to be futile. It will continue to progress, and his suffering will be prolonged. So the doctors should explain this to the patient and the family. I mean, of course, the patient is not in a condition to be able to understand, but to the family, and strongly recommend against intubation and ventilatory support, right? So, yeah, it's wonderful to see so many of you on this platform. I hope everyone has had a chance to put in your choice, your option. So the first one is oxygen is low. We need to intubate this patient and put him on a ventilator. Option 2 is We're not sure he's going to improve, but the family is saying you must do everything. So we are bound to intubate him and put him on the ventilator. And the third option is to talk to the family about limiting life prolonging treatments and try to convince them or recommending against intubation and ventilation. I see some people are still putting it up on the chat. We know that 30 people have voted at the moment, right? Of 80 on the poll. Okay, so I think we'll end the poll there so that we have a little more time for discussion. I'm sure that this would have made us think a little bit. About 20% of us thought that now that the oxygen is low and he has come to the he has come to the hospital, to the emergency, we must put him on the ventilator to improve his oxygen saturation and save his life. And about 31% of us felt that even though we know that the outcome of this intervention is not going to be very beneficial, but the family has told us to do everything, right? So we don't have a choice but to intubate him and put him on the ventilator. And about 49% of us feel that it would be wise to have a discussion with the family and recommend not intubating him and ventilating him or not putting him on a ventilator. So I'm really glad that we've had a chance to think about this. So I think it's a good starting point for us. What is it that we are trying to say in this scenario, or what is the ethical question that is before us, right? So for lack of time, I would have loved to ask some of you for ideas about what is the ethical question that is facing us, but I'll just help us with the question. And it's very good for us to think about what ethical question are we dealing with when we face clinical dilemmas, ethical dilemmas in our daily practice. We must ask ourselves, articulate the question, because that helps us to think clearly. So I think the ethical question here would be, would it be ethically permissible to withhold life-sustaining or life-prolonging treatments for Mr. Kumar, right? So that is the question. Given the information that we have, would it be ethical or ethically permissible to withhold life-prolonging treatments for Mr. Kumar? So I know that offhand, with a lot of experience, there is, we are usually trained to save life. We are usually trained to intervene to correct the physiology that has gone wrong. And here we have a lot of physiology that's gone wrong, right? We have a patient whose sensorium is low. We have a patient whose oxygen saturation is low. We have a patient whose blood pressure is low. So our reflex action when the oxygen saturation is low is to start oxygen. And if that doesn't help, then to intubate and ventilate the patient so that the oxygenation can improve. Our reflex action is to, administer IV fluids or maybe inotropes if the blood pressure is low. But there are certain things, certain details that we know in this scenario that make it a different kind of approach that we would have. Yeah. So when we are faced with ethical issues towards the end of life, and do we all agree that this is sort of towards the end of life for Mr. Kumar? We know that he has a terminal, incurable, advanced disease, and he is not going to completely recover, right? Everybody is with us on that?
Yes.
But now he has come to the emergency room, and the complexities are that he is unstable and that his family wants everything to be done for him, right? So there is a very useful framework which I want to introduce to you, and this first scenario that we have is quite simple, and it helps us to look at the different dimensions of the information that we have about this particular patient and how those different dimensions would help us to come to a reasonable ethical decision about this. Okay, so it's called the Johnson's 4-box approach, and we will also share with all of you the link to that and the articles. It's a really helpful tool for us to look at and assess each of our patients so that together we can make good decisions for them. Okay, so there are four main dimensions in the Johnson's four-box approach. First is the medical indications. I'll just state them very simply. The medical indications, that means what are the facts of the matter? What are the medical details of this patient? What is his diagnosis? What is the stage? What is the prognosis? What is the likelihood that with or without treatment, he will make a reasonable recovery? Okay. So those are the medical indications. The second is quality of life. So what we mean by quality of life is two things. One is, what was the quality of life pre-morbidly, as in before this particular event that has brought him to the hospital happened, what was his quality of life? And the second one is, with the intervention that we are proposing or suggesting to withhold, what is likely to be the quality of life after that intervention? Okay, so quality of life before and after the intervention. And the third dimension that we look at is patient preferences. So what is it that the patient wanted? What was he like? What did he talk about? What were his desires? What were his wishes and values? Right? So what were the patient's preferences? Now, it's very important for us to note that as emergency medicine doctors who are in the casualty and this patient is brought comatose, and we may never have met Mr. Kumar before personally, so we may not know what his values and desires are. But there are people around who know about him, who know what he wanted, who know what his desires were. So they are the source of this information, or even better still, if we have documented what his wishes and desires were, right? So we're talking about patient preferences. When we are able to talk to the patient, then we can firsthand get that information from the patient so that that can enable us to make the right decision for him or her. And the fourth dimension is contextual issues. Okay, so there may be certain contextual issues that also speak into the situation that are not related to the first three dimensions, that are not related to, say, the medical indications or the quality of life or the patient preferences, but they have very important bearings on the situation. Okay, so under contextual issues for us in India and in the practice of medicine, I think one of the very important contextual issues that we face is financial issues. That they are things that that is an issue that really comes into play very significantly. But it's important for us to remember that financial issues are not the issue that will help us to make an ethical decision. And we'll see how that happens, right? So, like we said, medical indications, quality of life, patient preferences, and contextual issues. So if we look quickly at Mr. Kumar's scenario, we know under medical indications that he has an advanced disease, right? He has advanced cancer, which is beyond cure. He has exhausted his treatment options, and he now has distant metastasis of the disease. And it is very, very unlikely, almost certain, that this disease is irreversible and incurable. Okay, so those are the medical indications or the medical details of the patient. Quality of life. What do we know about his quality of life? What was his situation before he came to the emergency? Right? We read in the scenario that he has been progressively deteriorating, and for the last 2 months, he's been completely bedbound, right? He's been completely dependent on all his activities of daily living. And if we look at what is the likely quality of life if we were to intervene with, say, intubation, ventilatory support, what is the likely quality of life likely to be, right? So as we can foresee, suppose it was a patient with a pneumonia, right? And no matter how sick they were, maybe they had septic encephalopathy and were comatose, maybe they were in shock because of sepsis, maybe they were severely hypoxic. But we know that if we intervened in that kind of a patient, put him on ventilatory support, supported him with oxygen, antibiotics, inotropes, fluids, whatever was required, that patient was likely to make a full recovery and go back to a normal quality of life, right? But we know that for our patient Kumar, that is not the case. His quality of life before as well as after the intervention is likely to be very poor. And then when we look at patient preferences, unfortunately, in Mr. Kumar's case, we do not have any documentation or any understanding of what he desired, but there's still a chance that we can talk to the family and find out, what did he say? What did he want? Did he know that he had cancer? Did he know that he was likely dying? What was his approach? What were his thoughts? What did he want? What kind of a death did he want? Did he want to be brought to the hospital? What did he say about how he wants to spend the last days of his life, right? So patient preference is something that is very, very precious, very important to us. And then contextual issues. So here now we have a family who's brought the patient and want everything to be done for him. So it does not look like finances are a big problem here, right? It doesn't look like there is a significant financial issue, but we can also ask about other issues that might have a bearing on the decision that we make together for this family. Yeah. So once we look at these 4 dimensions, what would you think, based on these, what would be the best thing to do for Mr. Kumar? Yeah? Does anyone want to rethink their answers? Is it always the best thing for us to intervene with the technology that we have just to correct a physiological number? The saturation is low, we must get it up. And therefore, since we're not able to do it with oxygen, we must do it with ventilatory support. Or after this holistic, nuanced thinking about what is the best thing to do for Mr. Kumar, would there be something else that we would choose? Right? So something for us to think about. And I think as we think about these decisions more holistically, we will have more confidence in being able to make decisions that are not like a knee-jerk reaction, you know? Anybody who comes to the hospital with a low saturation, we will think of intubating and putting on a ventilator. But when we think in a nuanced way, when we think about all the different dimensions, we will be able to make better decisions. So you would imagine that if Mr. Kumar were intubated, put on a ventilator, what are the chances of his recovering from his disease? They're extremely low, and he is likely to be committed to the ventilator with an uncomfortable pipe down his throat, with a nasogastric tube, probably with restraints, probably with lots of IV fluids, probably in pain, probably separated from his family who will have to wait outside the ICU with almost no hope of him recovering. And that would be the last memory of them, of their dear loved one in the ICU, away from them, dying alone. That doesn't sound like a very good quality of death, does it? If we were to think about our own deaths, that's not the kind of way we would like to have our last days if we were in Mr. Kumar's place, right? So probably for Mr. Kumar, the most ethical or it would be ethically permissible for us to withhold life supports in Mr. Kumar's case. So Rupa, do you have any reflections or any?
Yeah, so Dr. Ashita, is there something specific that, because see, this is going to be an issue worldwide, and there'll be different thoughts about it. So do you think there's something that we need to think about when we try to make a decision like this? Like, we need to like put ourselves into some picture before we kind of make a decision like this? And if so, why should we be doing that?
Yeah. So I think, you know, the advantage that we have with a lot of bioethical thought and discourse is that we have more organized ways of thinking about end-of-life care decisions, and we have progressed from the default of just doing what is required to correct physiology, you know. So the discussions that we had about how to think about this. And the reason, our grounding, our foundational understanding is that Mr. Kumar is a precious person created in God's image, right? And because we want to uphold his dignity, because we want to reduce needless suffering, and because we want to reduce harmful or burdensome treatments that are not going to be beneficial, we would like to withhold life-supporting treatment for or life-sustaining, prolonging treatment for Mr. Kumar.
So basically made in the image of God, and for him to have a dignified life even at the end of life, right?
Correct. Yes.
So who do you think should be the one who should be making this decision?
Yeah. So I think this is a really important question, Rupa. Very often in the Indian scenario, what we find is that people who suffer the disease, the patient is often left out of all the discussions regarding the care, regarding their care and the plans that are made for the care of the patient. So I think it's really, really important for us to affirm the autonomy of the person, of the patient, in making these decisions, and also to recognize that there may come a time when the patient will lose the ability or the capacity to make their own decisions, and then will be at the mercy of whoever is around, to make those decisions. So it's really helpful for us as healthcare professionals to document and have these conversations ahead of time. That would be the best that we could do, so that people who are living with life-limiting illnesses will have the ability to express their wishes and desires about how they would like to be treated when they lose the ability to make their own decisions. So I know that it is a hard conversation to have, but it is a beautiful thing to be able to give that, to empower our patients with being able to make that decision. So having conversations before they lose decision-making capacity. But of course, once they lose decision-making capacity, like Mr. Kumar, he was brought to the casualty and he does not have, he's not conscious now probably because of the secondaries in his brain. He's got raised ICT, so he's got a low sensorium, and he's not going to be able to tell us what he wants. But there was a time when he could, and we should capitalize on that time with conversations and document these conversations in the patient's chart, so that everybody who reads that document will be on the same page and will understand what he wanted. But that not having happened, suppose we have not been able to have that conversation with Mr. Kumar, then we follow what is called surrogate decision making. That is decision making by the people who are closest to him, and usually this is a family member, but ideally it's somebody who's really close to Mr. Kumar and knows what his wishes and desires were. And even when a surrogate decision making, that is somebody instead of the patient is making the decision, it should be someone who who makes the decision not based on what they want for him, but what he would have wanted for himself. So somebody who has had conversations with him and understands his wishes and desires, So these are two standards for surrogate decision making. One is called a substituted judgment, and the other is called the best interest standard. So substituted judgment is when another person makes a decision based on what they know the patient would have wanted, right? And sometimes that may even conflict with what they themselves want. But they will make the decision based on what they want, what they know that the patient would have wanted. That is the standard of substituted judgment. And the next best standard, the lower standard, is the best interest standard. I think that's what we default to the best interest standard. We will look at the facts of the matter, the medical indications, and all the other things, and we will make a judgment or a decision, or family members will make a decision based on best interest for the patient, right? But substituted judgment is a higher standard, which we should aspire to. If there are people who know the patient well, we must carry out what the patient would have wanted, right? So that's about surrogate decision making, Rupa.
So basically, to have this conversation over a period of time, if it's possible. If not, have a person who understands you better and helps you take that decision when you're really not in the state of mind to do that, right?
Correct. For our patients, yes.
Yeah. So I guess instead of being very emotional and giving the person a terrible quality of death, even a good palliative care would be even much more beneficial to such an individual. But I guess very often in India or the Indian health scenario, we are very constrained by the very fact that the majority of situation, the healthcare, the expenditure cost out of our pockets for our patients. So all of this is very important consideration, but we often make a mistake of prioritizing this over the more important questions, which is the ethical considerations. So even in the above scenario, even if Mr. Kumar's family had absolutely no resource restraints, it would be the other factors that should receive priority in making the decision regarding his invasive mechanical ventilations. And most of our time, our healthcare teams, including us, we are so focused on physiology that we just miss the bigger picture, right?
Very true, Rupa.
All
Yeah.
right. So I just change the scenario a little bit by maybe Mr. Kumar or Mr. Ramesh, whoever. So let's say we got time to discuss with an individual. So this Mr. Kumar Ramesh is now a person who's on regular with you in your hospital. He has coronary artery disease with an old myocardial infarction. He has severe left ventricular dysfunction, and he's a chronic renal failure patient with an advanced renal disease. Let's say his creatinine is somewhere between 5 to 6. Renal replacement therapy, very idealistic, but how often in India and how much can we do that? So that's also not an option, especially in his case due to financial reasons. And he and his family have know about it, and they have decided against this. These are already been in discussion. You've also have the discussions with him. So he himself knows that his long-term prognosis is not very good. It's poor, and but presently he has a good quality of life, and he's in the house, he's there, he has no major problems, but he's walking around ambulant in the house, has meaningful relationship with his caring family. He's bought hospital today with severe respiratory distress from acute pulmonary edema that could be due to his heart problem, due to his kidney problem, and he's not communicated any preferences for the ventilatory support. Though, by the multiple conversations you've had with him at so many different points of time, we know that he doesn't want to prolong a burdensome treatment that is not sustainable for this family. So, in this is now like how you said, you already know, you already spoken to him, he knows about his condition, but today he just ended up in an acute stage. So, in this case, what would you recommend? Do we have options again for the ventilatory support in such a case?
Thanks, Rupa. Yeah, so now that we have had one example of looking at the different themes and different dimensions of that will help us to make an ethical decision about life prolonging treatments, shall we exercise our minds a little bit and go over those four thematic areas: the medical indications, the quality of life, the patient preferences, and the contextual issues, right? So here, Rupa has told us about Mr. Ramesh, who has both heart disease and kidney disease. But he is relatively sort of controlled and has got a fairly good quality of life, walking around the house, having meaningful conversations and relationships with his family. He knows that in the long run, he will not go in for hemodialysis because he lives in a little village which is very remote. And even if dialysis were available to him free of cost, he's not able to make the journey to the city twice or thrice a week to be able to access that. And they, as a family, have made a decision. He has lived a good life. He does not want to burden his family or himself. For him, that quality of life is not acceptable. So he does not want dialysis. And now we have Mr. Kumar, Mr. Ramesh, who was quite well till this morning and has come with sudden acute breathlessness. And in the ER, or in the casualty, we made a diagnosis of pulmonary edema. So, what would you recommend for Mr. Ramesh? So, to make it a little complicated, there are 4 options. So, the first option, and I want you to think carefully, the first option is that you would ventilate anybody who comes to the emergency with a low oxygen saturation. And therefore, you would intubate and ventilate Mr. Ramesh. So remember, we are talking about not only what we are going to do, but also why we are going to do it, right? Sometimes we may do the right thing, but to be able to do the right thing with the right reasoning and the right motivation, the right reasoning is very important. Okay, so that would be the first one. Ventilate anybody who comes to the emergency with a low oxygenation. Second is, Mr. Ramesh already told us clearly that he does not want hemodialysis. We've got that documented in the chart. So we should assume that he does not want even short-term ventilatory support. Okay, that's the second option. We will not ventilate Mr. Ramesh because we already know that he has said he does not want hemodialysis. That's one type of life-prolonging treatment. So we will extrapolate that and assume that he probably will not want ventilatory support as well. And so we will not ventilate him. That's the second option, right? So remember the options in your mind. First one, ventilate everyone with a low saturation. Second one, he didn't want dialysis, so we assume he won't want ventilation either. Third one, now if we put Mr. Ramesh on the ventilator, we will be stuck with him on the ventilator. We won't be able to remove the ventilator. Once we put it, we are stuck there. And we don't know how many days he may be on ventilatory support. So it's better not to intubate him. So we won't ventilate at all because we know he's already said he does not want burdensome, long treatments, life-prolonging treatments. And the fourth option is to give a trial of ventilatory support. That means we say now, this is a person who was well and walking around yesterday, talking to his family and everything, even this morning, but now he's suddenly become breathless and come with with the respiratory distress. So why don't we try to clear his pulmonary edema with a short ventilatory support? And suppose he does not improve after maybe 24 to 48 hours or even shorter than that, we can always withdraw ventilatory support, right? So the first option, intubate everybody who comes with low oxygen, therefore intubate, that is ventilate Mr. Ramesh. Second option, he doesn't want dialysis, so he probably doesn't want ventilatory support as well. So we should not ventilate. Third, once we put him on ventilation, we'll be stuck there. So we don't want that. We won't be able to withdraw then. So let's not intubate at all. And fourth option, give him a trial, a time-limited trial of ventilatory support. Maybe he can go back to his original quality of life and live for another few months. Who knows, even years. So let's give him that support. And if he doesn't improve, then we will withdraw ventilatory support. Okay. So let's see. Okay, yeah, everybody in the chat box. Okay, very interesting. We have a few for number 2. We also have a few for number 4. It's almost neck and neck. Yeah, although we seem to be getting more 4s than 2s. Come on. Give it a thought. What would you do? इनको वेंटिलेटर पे डालेंगे या नहीं डालेंगे? और अगर डालेंगे या नहीं डालेंगे तो क्यों नहीं? Okay, sure. I think again, and thank you so much for participating. In the interest of time, we'll wrap it up. But thank you. I see a lot of 4s.
Yeah.
That's wonderful. Again, there's no absolute right and wrong answer, but there's just a way of thinking about it. So Rupa, what would you choose?
I think I would give a trial
Okay.
for some time. And if it's really not working, then maybe I'll have to sit with the family and discuss with the family and then go ahead with it.
Right. Yeah.
But like you
Okay.
said, there's no rights and wrongs in that, but that would be like a decision which,
Probably and ethically permissible. Okay.
yeah,
So how would
put
you?
myself in the Johnson's 4-box scenario, I guess.
Right, right. So shall we quickly just review the Johnson's 4-box, the 4 thematic areas? What are the medical indications? We have here a person with heart and kidney disease, but both are relatively controlled. They are not particularly necessarily terminal without dialysis at this point. His creatinine is 4 to 5. He's got a good fluid balance. He's walking around. So he's not imminently dying without dialysis as such, right? Probably given a few more months or even years, as depending on the speed of the progression of his kidney disease, once it comes to the point where life cannot be sustained without dialysis, at that point, probably it will be futile or it will not match with his goals of treatment to intubate and ventilate him. But right now, it is not from the kidney viewpoint really that he's requiring ventilatory support, but because of a pulmonary edema, which is something that is potentially reversible, right? We have so many patients who come in pulmonary edema, and with the appropriate care, within hours, their pulmonary edema can clear, even though he is living with a life-limiting illness. And he has clearly told us, I do not want dialysis, right? So we're going to honor that. But just because he has said he does not want dialysis, we cannot assume that another beneficial treatment with relatively low burden should be withheld from him, right? So from that perspective, it would be okay to consider ventilatory support for Mr. Ramesh. And then quality of life, we said he was walking around the house. That's a good, relatively good quality of life. And after the intervention, that is ventilatory support, suppose we are able to overcome the pulmonary edema, he can live with the same quality of life, maybe slightly reduced, we are not sure, but he could technically go back to a similar quality of life even after the ventilatory support is removed, right? Which was very different from our previous patient. And then patient preferences, we've talked about what he said clearly that he didn't want. He didn't want ventilatory support. I mean, he didn't want dialysis. And a lot of discussions had gone around that. And we would not overrule or dishonor his choice in that. But this is a different intervention that we're talking about. So we don't put all life-sustaining or life-prolonging treatments in the same box, but we will think about each of them as individual options and consider what would be best for him. And then contextual issues. We are very clear here that this family is going to struggle to be able to sustain somebody on prolonged ventilatory support, especially in light of the fact that the long-term prognosis is poor, right? So we have all these 4 themes or dimensions of the Johnson's 4-box approach that we've thought about. And in light of that, probably the best thing for us to do for Mr. Ramesh, it would be ethically permissible to give Mr. Ramesh a trial of ventilatory support. So now what's the question that comes? Okay, once you've put ventilatory support, it's very hard to take it off, right? What do we think about that? What is the usual thinking, Rupa?
Just a clause in between, I guess. So if in case the person has also specifically established that he doesn't want any intubation, then that we would be in choice 2, right?
Correct. If he has very categorically in a prior discussion said that under no circumstance do I want to have intubation or ventilatory support, then that might be something that binds us. But again, I think sometimes these decisions or one of the things about these decisions that are made in advance is that it is a theoretical possibility at that point when they're considering in their minds that, okay, I don't want to be on a machine. If you ask, most people will say, I don't want to be hooked up to a machine. But if you were to explain to them more carefully and say that without this intervention, you are unlikely to survive. But with this intervention, in a few hours, you can go back to the life that you had a few days back. And it's not going to be extremely burdensome because, we are not talking about high-end antibiotics, about blood cultures, about inotropes, or about very expensive interventions. It's just a very simple intervention that over a few hours can change how things look, right? So I would say if a person has told me that, I don't want to be hooked up to tubes and pipes when I'm dying, I will not take that general statement as an indication that I should not intubate this patient for ventilatory for pulmonary edema. So it's very important for us to understand the spirit of their desire. But there may be people who understand all of this. No, not for a minute. I do not want to be put on that machine. I'm ready to go. I know that anyway, in a few months and years, I'm going to die. Even for a day, I don't want to be put on the bench. If we have had that kind of a detailed conversation, we've been able to discuss all the peculiarities of the situations, then I think it would be okay to, accept that. So rather than taking that as the bottom line, because Mr. Ramesh probably doesn't know about pulmonary edema, and he was living a happy life. He had a good quality of life. And so I think the next morning, if we were to have him off the ventilator and smiling, he would be happy that his life was saved. But suppose that doesn't happen and there's uncertainty there, then what would we think about withdrawing life support now that we have instituted it? So what is a general understanding or hesitation, Rupa?
That's what I'm saying. So would that withdrawal of life support equate itself to euthanasia then?
Very good question. So again, a quick chat, yes or no. Rupa says, would withdrawing life support from Mr. Ramesh, suppose we gave him the chance, we put him on ventilatory support, he's not improving. Okay, we gave it 24 hours, 48 hours, he's not improving. But now we've decided, okay, we made a deal. We said we would give it a time-limited trial. The time is up. Now we want to withdraw life supports. If we withdraw life supports for Mr. Ramesh, would that amount to euthanasia? Yes or no?
We started getting answers already, I guess.
Yes. Wonderful. Wonderful. तो अगर हम इस पेशेंट से मशीन निकाल दें तो क्या वो यूथेनेसिया होगा? Okay. Thank you. Yeah. So the answer, and I'm glad there are a few yeses as well. Yes. So yeah, just to touch upon the fact that the two things that we consider in limiting life-supporting treatments is withholding life support, that is not starting life support, not initiating life support. Second is withdrawing life support. That means we have started life-prolonging treatments like ventilatory support or whatever it may be, but now we want to withdraw it. We want to remove it, right? That's the second one. And the third entity is euthanasia, right? Euthanasia is when there is an action that has the motive or intention of causing death, right? In euthanasia, the intention or the motive is to cause death. Whereas in withholding or withdrawing life support, we are trying to avoid futile, burdensome treatments and allow the natural process to take its course rather than intervening with a life-prolonging treatment. Is that understood? It seems very subtle, and sometimes it seems like maybe you're just playing with words. But actually, in the practice of medicine, it's really crucial for us to understand this difference. So withdrawing and withholding life support has a different intention from euthanasia, where the clear intention is to cause death. So now suppose somebody is on life supports or life prolonging treatments, and we withdraw that life prolonging or life sustaining treatment. The most likely outcome of that is probably going to be death. But That is not the intention, and that is also not always the case. We have so many experiences in real life and so many stories of how life supports were withdrawn from patients, but they survived that and they went home. Our intention in withdrawing or removing the life supports is not to cause death, but to allow the natural process to take its course and to prevent or to protect them from harmful, burdensome treatments and from needless suffering, right? So again, 2 points to state: withdrawal and withholding life support is not the same as euthanasia. Euthanasia is where the intent is to cause death, right? Secondly, the ethical standing of withdrawing life support and withholding life support is exactly the same, right? So if you choose to withhold life support, the ethical impact or importance of value of that is the same as starting life support and then withdrawing it. So it's not that withdrawing life support is a more, what shall we say? It has more import than withholding life support. In fact, if there is a small chance that your life support, like ventilatory support or whatever it is that we are planning to institute, if that can have some benefit, if there's some chance that there can be a benefit and the patient can be reverted to a good quality of life, then it is worth trying that life support and then withdrawing it rather than deciding beforehand not to apply it at all, because we may lose that opportunity to make a difference with the life support. So I think it's very important for us not to think, okay, this is the diagnosis and therefore no life support, but to think in a nuanced way, again, like we did with the 4 dimensions, remembering that withdrawal and withholding life support have the same ethical standing, also remembering that removal of life supports is not the same as euthanasia. Euthanasia is distinctly with a intention of causing death, right? So these are some things for us to think about, Rupa.
Yeah, thank you, Dr. Ashita. I think I guess this was more of a sensitization into the entire aspect of withdrawal and withholding life support. And I know it's a really complex clinical scenario. And I think today, most of us who are attending this, we are sure that we would have been struggling just to understand even the gist of these cases. So I think we'd like to stop today in this session, and we shall continue this discussion further in our next webinar, in which we would be dealing further with the practical aspects of this decision making and also a legal framework for all these issues. So is that all right, Dr. Ashita?
Yeah, Rupa. Maybe if there is 1 or 2 burning questions, we
Yes.
can take them and yeah.
So there's a question, Dr. Ashita. So it's from Abhishek, and he says that even if a patient is insistent on not going ahead with a particular treatment, let's say a ventilator, as a decision is made in advance, how do we know if that decision comes from a proper ethical or a spiritual understanding? Say the person doesn't believe his life is valuable or doesn't have a strong view of being made in the image of God.
Yeah, that's a really important question, Abhishek, which is why, in our country, I feel like sometimes the importance that is given to advanced directives may not yield the fruit that we are looking for, except maybe in the elite communities where there is a much clearer understanding, or even there, I feel like, there can be challenges when people write on a piece of paper, I don't want to go on a machine, and then in a situation where they can actually be brought out very easily in a couple of days, they would be actually forfeiting that life-saving treatment, which may actually result in good quality of life. So we have to be very careful when we document these things, and it should be with a very as clear an understanding as possible. And also it is important for us to remember that we are the ones who are in a place of power. We are the ones who have all the knowledge, and people may have perceptions that are really, there may be simple things that they completely refuse because of a block they have in their mind without really understanding the impact of their choices. So it's very, very important for us to make sure that that within a conversation, we are able to draw out the nuances of their choices and the foundations of their choices. Like I remember there was one lady, recently in our ward, who had a gangrenous limb and needed it to be amputated. Like there was no way we could save her life without amputating. And she just kept saying no. And then finally, when we said, what is it that's making you say no? And, she said, it's going to pain. I don't want the pain. I can't bear the pain. You're going to cut off my limb. It's going to pain. So having her understand that's going to be absolutely painless, that she's going to be properly anesthetized, and that she will still lose the limb, but she will save her life, and that we will take care of the pain. So it's so important for us to have these conversations. And we may have said it before, but that's still a block for her too. So drawing out in conversation, making sure that they understand. And that lady happily went through through the amputation and lived a long life. So it's very important for them to have all the information that they need to be able to make the right decision. And sometimes it may take it may take quite a lot of time for us to be able to help them to understand everything so that they can make good decisions. And then about your question about, the patient doesn't believe his life is valuable. So I just want to bring in one point. There are some people who actually have clinical depression, and they may make a decision that impacts their life at a point when they're clinically depressed. So that is actually ethically and legally, we can overrule that decision until their depression has been adequately treated. So that means that a person who is depressed and is making a life-impacting choice does not actually have decision-making capacity. Just as much as a person who has, say, hyponatremia, or their sodium is very low, they're not in their senses, or they're having a psychotic episode and they're making a choice, their decision-making capacity is dulled, and therefore we can overrule their decisions and make choices in their best interest in those situations, right? So that's one situation. The other thing you were talking about, they may not have a strong view of being made in the image of God. Absolutely, that's a majority of our patients who do not understand those foundations of our faith. All the same, life is precious. And, just being created in the image of God gives us that awareness that life is precious. And so even without drawing on that particular doctrinal foundation, we can talk about the preciousness of life and how these decisions are very, very important, because their life is precious. Yeah, I hope that answers to some extent. Abhishek.
Thank you. Thank you, Dr. Ashita. Are there any more questions? Or maybe we can keep it for the next session also, Abhijit. So if you want to wind up today with this.
Thank you, Dr. Ashita, for, we know the time difference is really big, and it's night post-dinner time for you. So thank you so much for taking this time out for us to be able to give us more clarity on this topic. And Rupa, for your valuable insights, for both of you, for your valuable insights today. And for all the participants, as the Supreme Court continues to urge for a formal law, as CMAI, we remain committed to keeping all our members informed and prepared. And please do join us for the next session. So we'll dive deeper on the legal aspects of this decision, and we'll be joined by Dr. Ashita and Advocate Siju Thomas, who is with ADF, and will provide legal perspective on this topic. And also, I have shared a link in the chat box, so please do fill in your details. This will help us to be in touch with you and also share the recording of this, and also keep you updated about, because this is the series that we are talking about. So today is the first one, and we are hoping that we will do it every second Thursday of every month. So the next one will be, I think it will be 9th or 10th of April. So please fill in your details. This will help us to be in touch with you. So thank you for your time and commitment to ethical healthcare, and have a meaningful evening. Thank you so much.